Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 10th edition in the webinar series Happy Pulse in Hypertension. So last year, in year 2020, in the month of July, we have started this webinar series with the purpose to provide in-depth understanding in the management of hypertension, including the complicated cases. So today, we are yet again live with new and interesting topic in this webinar, 10th episode of webinar series. And today we are going to discuss about the managing hypertension after the heart attack, and just recently published final data of sprint trial. So is there any message from that new sprint data? So that is we are going to discuss today. And we are having with us our course director, Dr. J.C. Mohan sir with us. He is the behind this whole program, deciding the topics and providing us continuous mentorship in this program. So Dr. J.C. Mohan is the chairman and head of the Department of Cardiology at Jaipur Golden Hospital, New Delhi. He has extensive research experience and published more than 250 research papers in the various index journals. He is also a honorary fellow for the American Society of Echocardiography India, and he is the president of Apex Society for CM in Cardiology. And he has received various awards, including the Sujoy B. Roy Gold Medal by the Cardiology Society of India and Health Minister Award for the Meritorious Service. So with this, I hand over the session to Dr. J.C. Mohan sir. Over to you, sir.
Thank you, Dr. Mithilesh. It is again a great honor to be in this series of practice pulse in hypertension. And I am humbled, I am actually honored that two great personalities would be speaking, and we have two equally eminent faculty as experts on the who would be actually taking some of the Q&A and give their comments. Dr. Piyush Jain, I have known him for nearly 37 years. We were together in GB Pant Hospital. He's one of the best known preventive cardiologists of the country, very well read, currently Director of Cardiology in Head Department of Preventive Cardiology, Fortis Escorts Heart Institute, and of course extensively published. The more important thing is the in-depth knowledge which Piyush has got in the subject of dyslipidemia, hypertension, heart failure, ischemic heart disease, and diabetes. I think it will be a pleasure when you listen to him and you realize the depth of his analysis and knowledge. I am also actually again humbled to have Dr. V.S. Prakash, who is professor and head of cardiology from M.S. Ramaiah Medical College and Narayan Hridayalaya, Bangalore. And it actually is a great pleasure to know him. He is one of the foremost electrophysiologists of the country, and I have seen him publishing extensively and also doing these complex arrhythmia workshops. Although I left the field of arrhythmology about 21 years back when I left GB Pant Hospital, but I continue to be fascinated by this branch, and I salute people like Dr. V.S. Prakash who have carried the flame of arrhythmology in this country. And he has been awarded Nightingale Award for one of the 10 leading personalities in the field of medicine. And as I said, he is extensively, and you will understand how well-read and how humble he is with regard to the accolades, with regard to the experience which he carries in his head. I also need to introduce to you my two great colleagues who are the expert panelist, Dr. Major General Naveen Agarwal, who is the Director of Department of Intervention Cardiology, Max Hospital, Mohali, and I had a chance actually to be on several webinars with him in the past. He's an accomplished intervention cardiologist, a DNB examiner, and a former additional director general of medical services, Army, New Delhi, and visiting consultant to Army Hospital, R&R. It's a pleasure to have Dr. Naveen Agarwal. Welcome, sir. I'm humbled that you could come. And of course, not the last but not the least, Dr. Vijay Pathak. He is a senior professor, SMS Medical College and Hospital, Jaipur, and great interest in interventional cardiology, including structural heart disease, device implantations, and of course, endovascular treatment of aortic aneurysms. I welcome you, sir, to this expert panel discussion on the management of hypertension, special aspects. With those words, we will go to Dr. Piyush Jain, who is going to talk about management of hypertension after heart attack. As you know, hypertension is a major public health problem. It affects each of us. Actually, I will doubt in case many of us who are here, if half of us are not hypertensive. I'll be surprised actually. It is a ubiquitous universal issue, and somebody was showing a slide just before this program started, 200 million Indians having hypertension. I think that number is a gross underestimate. We do believe that if you take the ACC-HA criteria, the number should be around 325 million people. Largely, more than half of those people are not aware, more than half of them are not treated. And of course, control is dismal at about 10%. The fourth National Family Health Survey published actually last year in Public Library of Science 1 suggested. So we of course have many issues, many comorbidities associated with hypertension. Heart attack is one of those, and Dr. Piyush is going to take us through the management of hypertension after a heart attack. Floor is yours, Dr. Jain.
Thank you very much. Let me share my screen, please. So, can you see my slides?
Yes, please.
Okay, thank you. Thank you very much. So, Dr. Mohan, let me just first inform you that I was hypertensive at the age of 28 years when I was in cath lab working with you. But then I left interventional, cardiology, and I became normotensive.
That is great.
So my blood pressure has never risen after that.
I am incorrigible, actually. Can't leave the lab.
Okay. So coming on to the topic, the topic is hypertension after myocardial infarction. A very interesting topic, and I thank the organizers for giving me this topic to review the subject. And I will be talking mostly about the practical aspects. So before I start about myocardial infarction, I will like to say a few words about the blood pressure control in chronic coronary artery disease. So to summarize what we know about the blood pressure control in coronary artery disease, the randomized control trials on coronary patients suggest that the antihypertensive treatment confers CV benefit provided the systolic blood pressure is something between 130 to 140 systolic. Whereas a systolic blood pressure of less than 130 millimeters of mercury was not associated with consistent beneficial effects in the studies. So a reduced risk of CV events was observed in 2 trials, but no risk reduction was seen in 3 other trials. So to summarize, there is no consistent evidence in favor of very aggressive blood pressure reduction in presence of coronary artery disease. In fact, reducing the systolic blood pressure to less than 130 may be harmful also. Like, for example, in ACCORD, more aggressively treated patients showed a 3 times greater incidence of serious side effects. So the evidence suggests that this strategy of very aggressive blood pressure reduction in coronary artery disease may be associated not just with no advantage, but with some disadvantage. Then we have to consider the J-curve phenomenon. Now, this J curve phenomenon has been controversial, but in presence of coronary artery disease in patients who are at high cardiovascular risk suggests that J curve phenomenon does occur both in systolic as well as diastolic blood pressure. But I am focusing right now on mostly on systolic blood pressure. And to give you an example, the INVEST trial, which had a lot of patients with coronary artery disease, a reduction of systolic blood pressure between 130 to 139 millimeters of mercury was associated with a clear-cut reduction in the incidence of CV events compared with patients who remained above 140. So reducing the systolic blood pressure to less than 140 is certainly beneficial, provided the systolic blood pressure remains between 130 to 139. Likewise, in on-target trial also, patients, many of these patients who had frequent history of CVD, established CVD, a reduction in CV risk was seen when systolic blood pressure was reduced from a baseline value of 140 or more to between 140 and 130. But those who had an on-treatment systolic blood pressure less than 130, actually no beneficial effect was found. And patients in whom on treatment systolic blood pressure was less than 130 millimeter of mercury, both these trials showed a tendency for morbid or fatal cardiovascular events to increase progressively, and this clearly shows that it may be a J curve phenomenon. As diagrammatically you could see here, I'm sorry I cannot show you the pointer, but compared to a blood pressure, systolic blood pressure of more than 160, 150, more than 140, if you achieve a blood pressure between 130 and 140, you find there is a reduction, progressive reduction. On the other hand, when the blood pressure goes progressively lower than 130 and particularly less than 110 or between 110 to 120, actually the cumulative event rates for primary CV outcome actually shows a negative trend. Negative trend means a negative outcome. Now, on-target study also showed the same thing in regard to the primary outcome of combined, outcome as well as the CV mortality, myocardial infarction. The only exception was that there was a progressive reduction in the stroke event with further reduction in the systolic blood pressure to less than 130 millimeters of mercury. And the same phenomenon was also observed in a large value trial. Of course, these trials were not meant to know what is the best blood pressure for a person with or without CHD. Of course, they were high-risk patients, but the idea was different. But these are the observations related to the study outcome and on treatment systolic blood pressure correlating with the cardiovascular events. Either a single event like mortality or cardiovascular deaths, or a combined events, as in most of the trials, we have combined primary event. You find that reducing the systolic blood pressure, particularly to less than 120 millimeters of mercury, is actually harmful. I will not go through this aggressive BP reduction and stroke reduction. The only thing that I would like to say is that possibly the stroke reduction with further BP reduction is probably because of the better ability of the brain, and I may add to that the kidney also to auto-regulate the blood flow, and this may be reflecting in further reduction in the events in patients who have stroke in the past or those who are at the risk for kidney dysfunction. So switching over to the acute coronary syndrome. So hypertension is of course common in patients with acute coronary syndrome, and if you take the history of a patient, a history of hypertension is present in about 2/3 of the patients with ST elevation MI, and even a larger proportion of patients with non-ST elevation MI, they have got pre-existing hypertension. But whether the history of hypertension as a risk factor for acute coronary syndrome is important or not, anything? Okay. It seems that whether or not a patient has history of hypertension is not so important. Rather, more important is what is the actual blood pressure of a patient when he presents or she presents with acute coronary syndrome, whether it is ST elevation MI or a non-ST elevation MI or unstable angina. So coming on to the prognostic significance of admission blood pressure in acute coronary syndrome. And this we have to correlate with the outcomes. So what is the admission blood pressure and the outcome relationship? Well, the relationship I would like to say is that it is complex, and this is particularly so in the early periods following the acute coronary syndrome, and the reasons are many. Previous reports identified elevated blood pressure as an independent risk factor for mortality after acute coronary syndrome, but other studies identified elevated blood pressure as high as systolic blood pressure of up to 200 millimeters of mercury on presentation as protective against death. However, there is consensus that very marked elevation of systolic blood pressure beyond 200 millimeters of mercury is hazardous, primarily because of its association with intracranial hemorrhage. On the other side of the fence, several studies have also observed that low blood pressure, particularly systolic blood pressure less than 100 millimeters of mercury, are much more strongly associated with the risk of death than hypertension or elevated BP. So the nutshell is that very high BP or a low BP are actually more deleterious than moderately elevated blood pressure. We have to keep that in mind while treating a patient. And the treatment is often difficult as far as the blood pressure control is concerned during the time when the patient is admitted with acute coronary syndrome, because blood pressure is a variable which fluctuates significantly on acute coronary syndrome presentation because of pain. So this requires stabilizing the patient, making him more comfortable before focusing on antihypertensive therapy, unless the blood pressure is low or it's very, very high. Second is, an exaggerated blood pressure fall is not uncommon because of vasomotor instability. So the outcome and the conclusion that we can draw from this is that blood pressure control during ACS has to be more cautious and more gradual unless it is extreme. The other thing is the diastolic blood pressure. Now, the diastolic blood pressure I have not touched upon so far, but rapid and excessive lowering of diastolic blood pressure to less than 60 millimeters of mercury actually can impair coronary blood flow, because most of the coronary blood flow takes place during diastole, and therefore it can impair the myocardial oxygen supply in the setting of, particularly in the setting of acute coronary syndrome. So inpatient blood pressure for a patient who is admitted with acute coronary syndrome should be lowered cautiously to avoid precipitous fall in blood pressure. Another point that I would like to make here is, and remind everybody, that the anticoagulant therapy in acute coronary syndrome, and particularly the anti-fibrinolytic therapy or anti-thrombolytic therapy in severe uncontrolled hypertension, can lead to major bleeding complications. And the complications risk is further compounded by dual antiplatelet drug therapy, which is a standard of therapy in acute coronary syndrome. So, rightly so, uncontrolled hypertension has been a relative contraindication for thrombolysis. So, a patient who has got a blood pressure of 180 by 110 millimeters of mercury, that constitutes a relative contraindication for thrombolysis. And in such a patient, if thrombolysis is contemplated, then some effort should be made to reduce the blood pressure to a lower level before going for thrombolysis. So coming on to the hypertension management in the acute coronary syndrome. With these caveats in mind, fluctuating blood pressure, pain contributing to the hypertension, some patients prone to get marked fall in blood pressure, risk of intracranial or GI bleeding in patients with uncontrolled hypertension who are given aggressive anticoagulant or thrombolytic therapy. Hypertension management has to be judicious. Now, but what are the targets? Now, the targets for blood pressure in acute coronary syndrome actually have not been established specifically in the setting of acute coronary syndrome. In fact, no trials with outcomes have prospectively assessed BP lowering in patients with any form of ACS, whether it is ST elevation MI or non-ST elevation MI or unstable angina. So the BP goals as recommended in the guidelines, about which I am going to talk, and the specific antihypertensive recommendation in this population of ACS are largely derived from observational data and the trials which assess the benefits independent of BP lowering. Now, what does that mean? That means that we don't have a particular randomized controlled trial to look into what is the best blood pressure of a patient who presents with ACS. And in fact, we have to extrapolate the data from the outcomes with the agents which may have a beneficial effect on the natural history of coronary artery disease in the setting of acute coronary syndrome, that we have to treat the patient for hypertension. So data guiding the BP targets either during hospital admission and even as outpatient following ACS are virtually non-existent, and the AHA ACC guidelines suggest that a BP target of somewhere around 130/80 at the time of hospital discharge is a reasonable option. Coming in more details next, let's now talk about the antihypertensive agents which have a compelling evidence for use in acute coronary syndrome. And mind you, these agents which I'm talking about, mostly these agents, primarily they are not agents for controlling the blood pressure, but improve the outcomes based primarily on the hemodynamic status of a person, and secondly, the left ventricular dysfunction which may occur frequently in patients with acute coronary syndrome. So beta blockers have to be considered first, followed by RAS inhibitors, particularly ACE inhibitor, and as an alternative ARBs, and aldosterone receptor antagonist. Now I will finish off talking about nitrates here only, because nitrates are not primary antihypertensive agents, particularly in the long run. So nitrates are not recommended in ACS to reduce the events, that is well known, but they are known to relieve the ischemic pain. So one of the strong reasons for using nitrates in acute coronary syndrome is to relieve the pain, and as a collateral benefit, one could also control blood pressure, particularly in a patient who is in severe pain and has got acute hypertension, or the patient has got heart failure with acute pulmonary edema. So intravenous nitrates are recommended in this setting. But one should remember that nitrates should be avoided in patients with suspected RV infarction, and also those patients who have got hemodynamic instability. So coming in greater depth about the use of beta blockers in acute coronary syndrome. So we know that beta blockers have got a definite beneficial effect on the hemodynamics, because they not only reduce the heart rate but also the blood pressure. So blood pressure reduction, reduction in heart rate leads to a reduction in the double product, reducing the myocardial oxygen demand. Also, outcome studies have shown that early use of beta blockers and continued use of beta blockers, both in short term and long term, reduce the infarct size, reduce the early occurrence of sudden cardiac death, and also subsequent reinfarction. So I'm not going to present the data on that because I got a limited time of about 20 minutes. So ordinarily, when beta blockers are not contraindicated and we want to initiate a beta blocker in acute coronary syndrome for the benefits in terms of reduction in heart rate, reduction in blood pressure, and with the hope that it will reduce the infarct size, sudden cardiac death, and subsequent reinfarction, it is mostly the oral cardioselective beta blocker with absent intrinsic sympathomimetic activity which should be employed. And in these, in our country, we use metoprolol or bisoprolol, which should be initiated within 24 hours of symptom onset, provided the patient is hemodynamically stable. Carvedilol may also be a good choice because it has got an additional alpha blocker activity. So in patients with severe hypertension, not amounting to hypertensive crisis, carvedilol, oral carvedilol is something that could also be used because it may have an additional effect of alpha blockage along with beta blockade. Now, what about intravenous beta blockers like esmolol or intravenous metoprolol? Well, they do have benefits, but their usage should be restricted to those with severe hypertension or tachycardia with an ongoing ischemia and a low risk for hemodynamic compromise. So limited role for intravenous beta blockers. Nevertheless, in selected patients, intravenous blockers in beta blockers may be used, but mostly in the setting of acute coronary syndrome, it is the oral cardioselective beta blockers with absent intrinsic sympathomimetic activity with or without additional alpha blocker action are the ones that should be used in a hemodynamically stable patient. Now coming on to the calcium channel blockers. Now there may be some patients where beta blockers are contraindicated. Very few patients are there where beta blockers are contraindicated and the patient is hemodynamically stable, does not have LV dysfunction. Now in such patients, a non-dihydropyridine calcium channel blocker like verapamil, which is rarely used now, but diltiazem may be useful for ongoing angina, provided the patient does not have significant LV dysfunction. Now, this is something that is actually not a primary indication for hypertension, but for ongoing angina. And any benefit in terms of blood pressure control with the use of non-dihydropyridine calcium channel blocker in the setting of acute coronary syndrome is basically a collateral benefit rather than the primary benefit. But remember that unlike beta blockers, calcium channel blockers, they do not reduce the mortality rate. And they definitely increase the mortality in the setting of significant LV systolic dysfunction or pulmonary edema. So they are actually contraindicated. So if beta blockers are contraindicated for some reason and the patient has got LV dysfunction or they have pulmonary edema, never use a drug like diltiazem. Now what about the long-acting dihydropyridine calcium channel blockers like amlodipine? And I will talk only about amlodipine. No role for cilnidipine or benadipine, etc., and other newer calcium channel blockers for which there is no outcome data even in chronic situation. While long-acting dihydropyridine calcium channel blockers like amlodipine may be used as an add-on therapy in patients with hypertension, which is uncontrolled by beta blockers, ACE inhibitor, and diuretics. So it's a third-line drug for control of blood pressure in the setting of acute coronary syndrome. Short-acting nifedipine, very rarely used nowadays, but it should also be avoided in acute coronary patients. Now, coming on to the third class of drugs about which I listed in my summary slide for which drugs are to be used as compelling indications. The ACE inhibitors, they have a big role to play in the setting of acute coronary syndrome, not only for hypertension but also to improve the outcomes in terms of mortality, early mortality, reinfarction, as well as late mortality and heart failure. Now, ACE inhibitors have been used both early, that is in the first 24 hours or soon thereafter during admission, or in the long term, and in fact they have been investigated and trials have been conducted to look into the mortality benefit with the ACE inhibitors in patients with myocardial infarction, both with early use and late use and long-term use. And among the agents that have been used, one should remember that captopril, which is not being used anymore, more or less in this country, that has been investigated most extensively in the setting of myocardial infarction or soon thereafter. But other agents like lisinopril, ramipril, they have also been investigated, and the results are more or less the same. So you could divide the benefits of ACE inhibitor therapy in acute coronary syndrome in two types of trials, as I said. ACE inhibitor therapy, which was initiated early, that is within the first 36 hours of the onset of myocardial infarction, and continued short-term, so short-term benefits. And these short-term benefits in such patients, they are associated with reduction in infarct size and death. And mind you, this is not for hypertensive population with ACS, it is for all patients with acute coronary syndrome. So an unselected population where ACE inhibitor therapy can be given, and there are caveats to that also. Whereas patients with acute myocardial infarction and either heart failure or left ventricular systolic dysfunction, ACE inhibitor therapy, which was started earlier, that is 3 days or later following myocardial infarction, and continued long term, that is also associated with a reduction in LV remodeling, LV dilatation, and clinically about 20 to 25% reduction in the death, regardless of the baseline blood pressure. So here I would like to emphasize that the use of ACE inhibitor in acute myocardial infarction should not be limited to patients with myocardial infarction with hypertension, but to all patients where it can be given, provided the patient is hemodynamically stable, is not volume depleted, his kidney function is not deteriorating in the sense that it is the EGFR is not progressively increasing, and the systolic blood pressure is more than 100 millimeters of mercury. What about the benefits of ACE inhibitor in NST elevation MI, NST MI, or unstable angina as compared to ST elevation MI? The trials that I showed were mostly limited to the patient who had ST elevation MI, but the evidence for benefits of ACE inhibitors in NST elevation MI or unstable angina are largely extrapolated from ST MI population. So, both for hypertensive population with ACS as well as non-ST elevation MI or unstable angina, the benefits of ACE inhibitor are actually extrapolated, but they are likely to be there. So, to summarize so far, an ACE inhibitor along with beta blocker, unless it is contraindicated, is quite reasonable in most patients with acute coronary syndrome, both STMI as well as unstable angina or non-ST elevation MI, particularly if the patient has got left ventricular ejection fraction less than 40%, diabetes mellitus, or CKD without severe hyperkalemia. So this is, a slide showing the benefits in terms of death and major cardiovascular events with the long-term use of ACE inhibitor in patients who were recruited in different trials on a long-term basis, that is SAVE, IRE, or TRACE, using different, ACE inhibitors, not the one which is used very common nowadays, but the benefits in terms of readmission for heart failure, reinfarction, or death or MI, or readmission for heart failure were observed consistently in all the trials of ACE inhibitor therapy given for a long-term period of at least 1 year following left ventricular, following the acute coronary syndrome, and this benefit was most marked in patients who had LV dysfunction, and even more marked for patients who had heart failure, clinical heart failure. But as I said, ACE inhibitors should not be given to all patients, and for those who have got acute myocardial infarction and a low blood pressure with a systolic blood pressure of less than 120 millimeters of mercury at presentation, and you think that the patient may have critical hypotension or may be prone to renal dysfunction with over-aggressive treatment, one could always wait for initiation of ACE inhibitor therapy after about 36 hours or when the patient is more stable. There was a time when short-acting ACE inhibitors like captopril or enalapril were used, and it is still a part of the guideline that they may be reasonable for initial therapy, primarily for the reason that they have been used, particularly captopril in the acute setting, and secondly, because of the short duration of action, any hemodynamic compromise that occurs as a result of administration of an ACE inhibitor in the setting of acute myocardial infarction may be offset rapidly because it's not long acting. It has to be given at least 3 times a day. But then once you start and the patient is able to tolerate it, does not get severe hyperkalemia, does not get progressive increase in the fall in EGFR, the ACE inhibitor should be continued indefinitely. ARBs, well, they are not the first choice. They may be substituted for patients who are unable to tolerate ACE inhibitor, and there are cardiovascular event outcome trials like Valiant, which support a comparable efficacy, and it's not a superior or inferiority trial. It was a non-inferiority trial when initiated 10 days after myocardial infarction and continued for about 2 years. This is the Valiant trial about what I was talking about, that acute myocardial infarction setting within 10 days of onset. Well, these patients were ACE inhibitor, they were eligible for that, and high risk patients with the systolic blood pressure of less than 100, a high serum creatinine, or prior intolerance for ACE inhibitor or ARB was excluded from them. And valsartan was compared with the captopril. Of course, there was a combined arm of captopril valsartan, which did not show any benefit. But captopril and valsartan, well, valsartan all-cause mortality, there was no difference between the two. And looking at other outcomes like CV death or MI combined, or CV death or heart failure, or a combined CV death, MI or heart failure, well, valsartan was non-inferior to captopril in this setting, but mind you that it was not superior also. So valsartan should be used in patients with acute coronary syndrome, particularly only when the patient is not able to tolerate the ACE inhibitor. Coming on to the mineralocorticoid receptor antagonists. Now, these have come in a big way, particularly for the patients with resistant hypertension, chronic hypertension, I mean. But aldosterone receptor antagonists, they also have got a big role to play in patients with acute coronary syndrome, particularly in those patients who are prone to develop heart failure in future. So they decrease ventricular remodeling and myocardial fibrosis, and they are appropriate in patients with acute myocardial infarction complicated by LV systolic dysfunction or heart failure. And the benefit in terms of hypertension is incidental, of course. And the study which was done particularly in the setting of myocardial infarction was with eplerenone, that was FSS study, which enrolled patients with MI with LVEF of less than 40%, and showed that eplerenone reduced the risk of all-cause death by 15%, CV mortality by 17%, and sudden cardiac death by 21%. So will these benefits also be passed on to patients with hypertension? Why not? If the patient has got LVEF of less than 40%, the likelihood is that controlling blood pressure, which is an additional benefit of eplerenone in the setting, if provided the patient is hypertensive, is very much welcome. But remember that spironolactone, even though the benefits are nearly the same in terms of benefits in terms of heart failure as in RAILS trial, it has not been explicitly studied in ACS patients. It is the eplerenone which has been studied in ACS patients. So these are some of the details of with FSS, placebo. It was a placebo-controlled trial, and it was an event-driven trial. So high-risk patients, so high event rates. The follow-up was only 1.33 years median, and as one can see, the all-cause mortality was reduced by about 15% just in 1.33 years. Now, coming on to the thiazide diuretics, well, they are appropriate in selected patients who need additional blood pressure control, or in patients with evidence of rising filling pressure, pulmonary congestion, or heart failure. So I have talked about beta blockers, their roles independent of hypertension, with hypertension, ACE inhibitors, ARBs, MRA antagonists, and then of course nitrates in a passing way, and thiazide diuretics as an additional could be used for patients who have acute coronary syndrome, and particularly those patients who are going to be benefited by your antihypertensive therapy after the patient has been discharged. So coming on to the outpatient hypertension management following ACS. It is recommended that overkill even at this stage is not good if the patient has got coronary artery disease, and coronary artery disease is basically a diffuse disease. We may thrombolize the patient, we may do primary PCI, but generally the patient has got extensive atherosclerosis, whether it is obstructive or non-obstructive, that's a separate thing. But there is, because of atherosclerosis, there is a flow limitation, particularly in the setting of stress. And the stress could be hemodynamic, like reducing the diastolic blood pressure to less than 60, or reducing the systolic blood pressure to less than 130, substantially less than 130. So even in the outpatient setting, the antihypertensive therapy following ACS should be titrated slowly to avoid substantial reduction in diastolic blood pressure, and one should not allow the diastolic blood pressure to less than 60 millimeter of mercury. And this is particularly important in the elderly patient who have, very frequent isolated systolic hypertension, and also those patients who otherwise have wide pulse pressure. What about the duration of beta blocker therapy in patients as an outpatient? Well, the recommendations say that you continue beta blocker for at least 3 years, maybe indefinitely, but some evidence suggests, and this is from the meta-analysis of the hypertension trialist, that suggests the benefits of outpatient beta blockers. They continue predominantly in the first year post-MI, but these benefits are not because of the blood pressure control, but because of the effects of beta blockers on the occurrence of heart failure in the future. So this is my last slide, and this tells you about the AHA-ACC recommendations. And as you can see, despite the paucity of outcome data, particularly when hypertension control is the factor to be taken when we are treating a patient, for hypertension and looking at the outcome, the use of oral short-acting cardioselective beta blocker within 24 hours, if there are no contraindications, that is a strong recommendation. It's a class 1A. IV beta blocker for severe hypertension on ongoing ischemia is 2A, B, so not so strong. Delayed initiation of beta blocker for unstable patient, there is no doubt that it has to be class 1A. Nitrate for severe hypertension, well, it's class 1C. Long-acting dihydropyridine calcium channel blocker as an add-on after using beta blockers, ACE inhibitor, and maybe even thiazide diuretics. Once again, it is a class 2A/B recommendation. ACE inhibitor in persistent hypertension, and to that and above this persistent hypertension, I would like to add anterior MI with LV dysfunction, heart failure, or diabetes. It's a class 1A indication. ARB in ACE intolerant, it's class 1B, it's not class 1A, because ARBs are always an alternative ACE inhibitor. MRA like eplerenone in LV dysfunction or either heart failure or diabetes, well, this is 1A indication because it is definitely shown to reduce the mortality by about 15% in just 1.3 years. Thiazide type diuretic, if BP is uncontrolled with beta blocker, ACE inhibitor, or MRA, it's class 1B, it's quite reasonable. Now coming on to the target level of recommendation, while class and level, we are actually not very sure what is the best blood pressure, but looking at the overall evidence that we have, whatever limited evidence we have, in a patient who has got acute coronary syndrome, a target blood pressure while the patient is in hospital, it should be less than 140 and 90, provided the patient is hemodynamically stable. One should not be going very aggressive because it may actually cause rebound hypotension. And at the time of discharge, the best blood pressure could be around 130/80, and then you may continue and maintain that blood pressure during the outpatient management. So thank you very much for your patience. I think I have taken a lot of time, but thank you very much, Dr. Mohan and the organizers, for giving me this opportunity.
Thank you, Dr. Piyush Jain, for this exhaustive review of the literature on management of hypertension after heart attack. And you have clearly defined the gaps and lacunae in our knowledge and hence in the guidelines on this particular aspect. Several questions have been asked by the audience. We would get back to those questions with our experts after the second talk. And now I'll ask Professor V.S. Prakash to throw light on final data of the sprint trial. Dr. V.S. Prakash.
Thank you, sir. Thank you for having me here. Nice to have you as the moderator for the session. It's an honor, and I would probably briefly touch upon the recent data that's come in from the new sprint trial. Am I visible, sir?
Yes, you are visible, audible, both.
Thank you. Thank you. Yes, sir. The new sprint data, I think it was a wonderful selection by you. Something that's really a game changer. An extension of the sprint which came in 2015. So, in this corona pandemic, with regard to just initially, are we really touching upon blood pressure? 30% of the Indian population in 2017 showed that we're hypertensives, and awareness is just about less than 50%, and treatment is maybe about 1/3, and control is a dismal 10 to 15% in the hypertensive individuals. So that's the kind of issue we have in this country, and not only here, even the rest of the world. But we know that higher the blood pressure, higher is the risk, and we need to really scale down the pressures to probably as low as possible. And what is this low? That is what was the issue. We know that reduction of 2 millimeters of systolic blood pressure brings down the ischemic heart disease mortality by 7%, 10% reduction in the stroke. We know it's considerably more for stroke reduction versus cardiovascular risk. And so we know that. And then another important thing which was touched upon by Dr. Piyush is the J curve. So how low can we go? We realized that in this trial, when we started going below 130 millimeters of systolic and maybe 80 millimeters of diastolic or 75 millimeters of diastolic, there was a J curve. Higher pressures, lower pressures, both had higher mortality. When we touched a systolic pressure of 130 and diastolic of 80, was the right pressure, below which again we started to have higher increasing in the coronary issues, cardiovascular mortality. So based on this, the ESC and the European Society of Hypertension 2018 set a target. They said anywhere between up to 65 years of age, don't go below 130 systolic blood pressure, and in fact they set a higher level for CKD patients. And elderly, they said maybe 130, but I think 130 to 140 would be a safer range. Let's not be very aggressive in trying to bring down the blood pressure. So that is what was followed, and then came in the sprint. This was a landmark trial which set standards, and it said in patients with high risk for CVD, ACVD more than 10%, 10-year risk, they said they divided between two arms, the intensive treatment arm and the standard treatment arm. Intensive treatment arm was where they targeted blood pressure systolic of less than 120, diastolic. They didn't really qualify on the diastolic, but they said less than 80. And they tried to differentiate that between the standard treatment and intensive care. And about 30 to 40% of these patients were in the age group of 70 and above. So they were not differentiating the age. They were not saying you set a standard up to 60, 65 is this pressure and more than that is that. They said no, try and reduce blood pressures at all age, those with higher CVD risk, to less than 120 systolic. What did they find? At the end of 2.5 to 3 years, they found that the primary outcome, there was a hazard ratio of 0.75, p-value significant. And if you look at the secondary outcomes with regard to myocardial infarction, stroke, again the p-values were much lower in comparison with the standard treatment arm. It came down to 0.8, 0.89, and heart failure, death due to cardiovascular diseases, everything came down to 0.57, and death of any cause to 0.73. So that was what was clearly shown in the Sprint 2015 data. So based on that, we realized that according to the 2018 ESC and European Society of Heart Hypertension, setting a target of 130 and differentiating the different age groups probably was not really useful. And very clearly the sprint said the benefits and risks of intense blood pressure control did not differ between the age groups, and you set a standard of 120 systolic blood pressure. There was a little bit of controversy going on with the sprint trial, the way the blood pressure was recorded. See, normally they office readings, we take a reading of over 130/80, and that is the kind of targets that we set. Whereas in the sprint trial, patient was unattended to, sitting in a quiet room, 5 minutes, nobody disturbed, there was no nurse, nobody at all, and then it was an automated blood pressure reading. So there was a lot of controversy saying that could you duplicate this in your everyday practice and record blood pressure in such an ideal situation to really target 120 or below that. That's set a lot of controversy. So again, but they realized that the sprint trial was clearly showing a lower risk of CVD in patients with optimally controlled blood pressure lowering to 120. And so the American Association in 2019 said, let's set a standard of 130/80. You start treating somebody with, they said stage 1 is 130 and above, and 140 and above is stage 2. You start treating patients even at 130, especially with highest cardiovascular risk, and try and lower your systolic blood pressure to below 120, to 130. That was the American Association 2019 guidelines. Though because there was a controversy about the way it was recorded, though the sprint did say that 120 probably was the target. Then came in the new sprint data. This was in 1 year post follow-up. All patients who were all 9,000 odd patients who were in the sprint were again followed up subsequently. Most of them continued to receive the same kind of medications. What was the extension of this data we got from the new sprint data? It was again a duplication of what the 2015 data said, clearly setting that in patients with higher cardiovascular risk, reduction in myocardial infarction, reduction in heart failure, risk total death from cardiovascular causes, and stroke were considerably lower in the intense treatment group compared to the standard treatment group. So if you see among patients who are at increased cardiovascular risk, targeting a blood pressure of less than 120 millimeters resulted in lower rates of major cardiovascular events and lower all-cause mortality, rather than trying to set the systolic pressure somewhere between 130 or 140 in whatever age group, be it in the less than 60 or 65, or even in the septuagenarians or in the octogenarians. They did not differentiate, and they found consistent reduction in their CV mortality as also all-cause mortality in patients in the intensive treatment group. They used a combination of drugs. Mostly they were on ARB, asilsartan, they were on chlorthalidone, and also quite a few, 90% and above, were on calcium antagonists, amlodipine. And if you clearly see here, the primary outcome between standard treatment and intensive treatment, hazard ratio was as low as 0.3 in the intensive treatment group. And this remained consistent in over this 3-year period, even in a post-therapy, post-trial follow-up. And okay, that was one aspect. What about the long-term benefits of intensive blood pressure control on residual lifespan? Again, if you see patients less than 65 years, there was an extension by 3 years, and patient above 65 who are in this septa or octogenarians, again there was a considerable increase in the lifespan. May not be to the extent that you start treating somebody in the middle age, 3.5 years that you gain in the lifespan. You gain at least about 1.5 to 1.6 years with intensive control of blood pressure, even in the elderly. That is what was clearly shown in this sub-study of the sprint. Then there was another sub-study of the sprint mind. Here they were looking at the white matter, and they were also looking at the hippocampal volume. They said there was a marginal reduction in hippocampal volume which reflects Alzheimer's, but overall a decrease in the white matter decrease in the white matter with intensive blood pressure control again is clearly telling you that probably some amount of a retardation of cognitive mental function, which is a saying to Alzheimer's disease in the later. So you're definitely brought down your cognitive impairment, mild cognitive impairment, by intensive blood pressure control, as shown in the SPRINT MIND trial, which was a sub-study of the SPRINT. Yes, on one side, we seem to be having a lot of advantage in reducing all-cause mortality, CV mortality, and probably reduction in the mental impairment, cognitive mental impairment. But what is the downside? The downside has been hypertension, has been an issue, but did it result in more frequent falls in this intensive treated group? May not be. There was an increased incidence of syncope, but they really did not see that there was an increased fall, and that did not really convert into increased mortality. So there were more falls, more syncope, but did not convert into higher mortality, thereby negating the effect of this intensive blood pressure control on the hypertension and probably the syncope episodes that were seen in this sub-study. So they clearly said that did not amount to anything significant. What about the renal function? This is, I think, something very interesting. If you look at patients with normal kidney function who are recruited, there was a drop in the GFR in those patients, 30% reduction in the GFR, and this was also seen initially in the initial period. We know that this we notice in any patient with hypertension. We start them on ACE or ARB inhibitors. There is a reduced renal blood flow, and thereby reduction in GFR is bound to occur, but usually it stabilizes over a period, and this was clearly seen in this trial. The first 1 year they saw a drop, but subsequently kind of stabilized. What about patients with CKD? CKD, in fact, here it had a protective. They clearly showed that the albumin-creatinine ratio, there was a decrease in the worsening by 32%, and the beta-2 myoglobin decreased by 29%, and the alpha-1 myoglobin decreased by about 24%, again clearly showing that in patients with CKD, intensive blood pressure control did have a protective effect on the kidneys. So the renal outcomes, if you see, as I said, those with normal kidney function, probably there was an initial worsening of GFR, but subsequently stabilized. But in CKD patients, it was not so. If you look at the other safety events like electrolyte abnormalities, obviously when you use a thiazide diuretic, you're definitely going to see quite a bit of electrolyte disturbances, which is seen in the intensive control arm. So that was one issue that was seen, and hypotension was also another problem. Injurious falls were not really much. The hazard ratio was about 0.7. Acute kidney injury, as I said, initial drop in the GFR in patients with normal kidney function, but not so in patients with CKD. So what is the final report of intensive versus standard blood pressure control as per the SPRINT trial? SPRINT trial clearly said targeting blood pressure less than 120 lowers the rates of cardiovascular events and all-cause mortality, and also confirms that despite the age, aggressive blood pressure control targeting systolic blood pressure below 120 signifies a reduction, significantly reduces risk of heart disease, stroke, and death from these diseases, as well as all-cause mortality. So, and this was a robust data which was really noted, and there's an additional observation period of 1 year extra which we got from this extension of the SPRINT trial. When treatment was discontinued, but they were followed up, they continued to remain in both the arms, and same kind of treatment was going on in both the arms despite them being out of the trial. So probably now we are shifting our goals from JNC 7 to JNC 8, now coming to the ACC 2019, which said probably 130/80 should be a target. With the SPRINT extension data that we have today, should we go as low as 120 systolic is what remains to be seen. Probably debate in the final sprint data clearly tells us that we need to really go as low as possible, but definitely we need to take care of the probable, the adverse effects that you could probably see, the falls, electrolyte disturbances, so on and so forth, which you need to, especially in the elderly who benefit with low blood pressures, but at the same time have higher risk of this, critical reduction in the blood pressure. Thank you.
Thank you, Professor Prakash, for taking us through the final data of the sprint trial with an additional 1 year of follow-up, reinforcing the positive results of the previous interim analysis, reinforcing the safety, and also additionally showing a reduction in myocardial infarction, which wasn't there in the previous publication of 2017. I know that this is a paradigm changing study. However, paradigm hasn't changed because human beings take long time to adapt to new things. And even though some of us might adopt these changes, physicians and primary care physicians, by and large, in their practice, are not going to be practicing this kind of targets. More so when we know that the 90% of our hypertensive individuals are not at goal. Nevertheless, thank you very much. Excellent presentation. We would go to the questions and answers. Questions put by our audience and our experts, Professor Naveen Agarwal and Professor Pathak would be taking these initially, and then our two speakers can chip in. And let me start with the questions. So some of the questions may be unrelated to the presentations, but nevertheless, hypertension is such an important topic, and it of course bridges across many presentations. So we have a question by Dr. Senapati. Is there any dose adjustment required for ARBs, particularly olmesartan in CKD 3 or above? Which class is better in ACS patients? CKD, in ACS patient with CKD, ACE, ARB, CCB. I think Dr. Piyush has already replied to that, but we will listen to the view of Dr. Pathak and then Dr. Naveen Agarwal. Dr. Pathak, please.
Yeah, thank you, sir. Sir, what the general dictum is to be careful about giving ACE inhibitors or receptor blockers beyond 2.5 serum creatinine. That's the general dictum. And of course, the urine output and the potassium also has to be kept in mind.
Dr. Naveen Agarwal, sir, what is your viewpoint?
Yeah, absolutely. I think, ARBs and ACE inhibitors are renal-protective. So as long as your creatinine is not rising and your potassium is under control, I would prefer to give ARBs and ACE inhibitors. Of course, the caveat, as Dr. Pathak has said, is if to begin with, the creatinine is more than 2.5, then it is a little risky, especially in an unmonitored setting, where you can have dangerous hyperkalemia which may go unnoticed and can be catastrophic. So if it is 2.5, calcium channel blockers. If it is less than 2.5, definitely ACE inhibitors or ARBs.
Dr. Piyush Jain, what do you think about these two viewpoints?
I think what we should be doing as a clinician is to not rely on the first serum creatinine or serum potassium. If the patient is hemodynamically stable, we should be doing a repeat electrolytes as well as serum creatinine. If the patient is hemodynamically stable at 24 hours also, he has a normal serum potassium and his serum creatinine is not rising and it was not high to begin with, there is no harm in starting with an ACE inhibitor. Are you talking specifically about ARB? Well, the indication and contraindications are nearly the same. There is no difference between the two.
Yeah, I would agree with you, but I'll ask Dr. Prakash, any difference in opinion, sir?
So more or less the same, but I think some of the nephrologists say you can go up to 3 milligram creatinine. 2 point, rather than 2.5 up to 3, you can still try and use either ACE on an ARB, but definitely you need to keep a very careful watch on further worsening of the GFR or the potassium values.
Yeah, I do agree with you. The nephrologists with whom I interact, especially Professor Vijay Kher and other, have consistently maintained that there is no threshold of serum creatinine at which ACE inhibitors or ARBs need to be stopped. The only concern should be progressive rise in serum creatinine and or hyperkalemia. If one of these two things is occurring, you need to change your strategy. Otherwise, the anti-RAS agents are renoprotective right up to very low EGFR, may not be in patients who are on maintenance hemodialysis, but till they are not on dialysis, anti-RAS agents continue to be renoprotective. Besides being anti-hypertensive drugs, of course, the risk of hypertension, risk of hyperkalemia continues to increase as the EGFR goes down. So having taken care of that question, we have a related question. Again, the same sequence we would follow. This is Dr. Vijay Gupta. He says, well, there is albuminuria present in some of the patients with controlled diabetes and hypertension. Now, both diabetes and hypertension are controlled, but they are of long-standing duration. Albuminuria is present. All other related tests are okay, which means that the EGFR are not too bad. And albuminuria has been consistently rising. How will you manage? So essentially what Dr. Vijay Gupta wants to know, there is progressive increase in albuminuria over a period of time in a patient with controlled diabetes and hypertension, even though the EGFR is relatively constant or falling very slowly. What would be your approach? I will start with Dr. Pathak.
Yes, sir. So it is very well known that the microvascular complications of diabetes, even with stringent control, might continue to progress, and hence in such a situation also a control of hypertension should be more by ACE inhibitors or receptor blockers, and more aggressive control of the BP is required. Of course, it should not be less than 120, but around 130, maybe less than 130, with a watch on the renal output, urine output, and the creatinine.
Yes. Dr. Naveen, sir?
I mean, basically, we should have a very stringent control over the BP, provided the albumin is, excretion is increasing. And I would again prefer ACE inhibitors or ARBs as they continue to be renoprotective. Beyond that, there is nothing in particular as far as hypertension is concerned which can control the albuminuria. It is more a long-standing effect of diabetes, and so we can control the diabetes better. We can control the BP in a stringent fashion, and preferably use ACE inhibitors. That is as far as we can go.
I would like to contribute.
Yeah. Yes, Dr. Jain. Yes, Dr. Jain.
Yeah. So albuminuria, which is progressive, one thing is clear that unless contraindicated, ACE inhibitor or ARBs should be given. That is number one. Second is, what if the patient does not show a decrease in albuminuria or stabilization? That is a very important question, because in our day-to-day clinical practice, we find that the patients keep on having albuminuria with no change as a result of ACE inhibitor or ARBs. Now that's a difficult proposition, and of course, better control of diabetes, better control of blood pressure, giving full doses of ACE inhibitor or ARBs. That is something there. But nephrologists also suggest two more things. One is supratherapeutic dose of ARBs, which means the top dose of telmisartan, for example, is 80 milligram, but they frequently advise 120 milligram or even 160 milligram of telmisartan every day, which no cardiologist will actually be prescribing in day-to-day clinical practice. But I have gone through the literature, and there are some studies which have shown that supratherapeutic doses of telmisartan may be more beneficial than the top dose of telmisartan, that is 80 milligram. That is number one. Of course, it goes without saying that one should not get severe hyperkalemia as a result of that, or progressive decrease in the eGFR. The other thing in refractory albuminuria is the use of mineralocorticoid receptor antagonist. They add on to the beneficial effects of ACE inhibitor or ARB in this setting, and they are also recommended as an additional strategy for controlling albuminuria where the patient is not responding well. So if the urine albumin creatinine ratio is showing no improvement, or it is still showing a urine albumin creatinine ratio which is not acceptable to us despite the traditional therapy, MRA antagonist is another strategy for that.
Good. I would by and large agree with the viewpoints given. There are only three class of antihypertensive agents which have renoprotective properties as well. All anti-RAS agents, number one, SGL2 inhibitors, number two, and MRA, particularly Finrinon with the recent Fidelio DKD trial, comes the third class of agents. But I would suggest that somebody who has a progressive albuminuria needs to be investigated. A renal biopsy would be in order, and some of these patients may have another associated disease which might benefit from other therapy. We come to question number 3. It is by Dr. Das. It says which agent we should use in patients with hypertension and post-MI heart failure. Now his choice is spironolactone, eplerenone, or torsemide. I think what we'll do is we'll ask, Piyush has already answered, but we'll ask Piyush first, then to Dr. Pathak.
Of course, there is no doubt that in such a patient, eplerenone is the drug of choice because we have got a trial which has shown the benefits. Spironolactone in chronic heart failure, yes, benefit has been shown, but it was not a trial of patients who were post-MI.
Yes, I do. You know, Dr. Piyush, there is a very interesting data about the FSS trial, which I came across some few months back. The FSS trial says that in case the eplerenone was started within 7 days, patients benefited. But if it was started after 7 days, patient did not benefit. Now that is very interesting data actually. This is a post hoc analysis and it has to be taken with a pinch of salt. Obviously you can analyze and dissect data in multiple ways, but it just says that if you have to use MRA like eplerenone, you should be starting very early on in acute myocardial infarction with heart failure.
Yeah, right.
Yeah. But torsemide as an anti-failure therapy and anti-hypertensive therapy is also reasonable. Most of us probably would combine torsemide with eplerenone. The combinations are available, or maybe spironolactone and torsemide. The combinations are available. We go on to the next question because there are plenty of questions, and if we start actually discussing amongst ourselves, we'll be here whole night. Next question by Dr. A.K. Mehta. He says, what is the status of beta blockers as an antihypertensive in young hypertensive below the age of 50 years? Now we'll start with Dr. Pathak. Dr. Pathak, sir?
Please unmute yourself, Dr. Pathak.
Yes, sorry, sir. So beta blockers as the first line therapy for antihypertensives in youngsters is not, unless we have already have a background information that the person has a high sympathetic discharge and under stress, those kind of situations, yes, beta, or maybe associated diseases like heart failure or coronary artery disease, then beta blockers might be also be useful as antihypertensive therapies.
Yeah, the fact is that beta blockers as an antihypertensive drug of choice or first line in young hypertensive individuals, only two guidelines promote it. The Hypertension Canada guidelines and the fourth series of the Indian hypertension guidelines, Indian guidelines on hypertension. But the Europeans and American guidelines classically continue with the same way of treating hypertension. Young hypertensive anti-RAS agents are first choice, followed by C or D, and then of course a beta blocker.
I think so. One issue is erectile dysfunction with beta blockers in young patients and low energy levels. I think that should also take us away from using beta blockers as first line.
I think I would agree and disagree both on this point. Beta blockers actually cause erectile dysfunction much more in older people. Younger people, unless they have a lot of anxiety, and beta blockers should help in that situation, don't get erectile dysfunction. We recently have actually looked at this aspect practically in large number of people, where we have used metoprolol as much as 200 milligram a day, and we specifically asked for erectile dysfunction worsening. We didn't ask erectile dysfunction per se, worsening, and there hasn't been any worsening. So the erectile dysfunction to some extent occurring in hypertensive individuals is another story, but worsening with beta blockers probably I think is exaggerated. It is there, but it's not that much. But I would agree with you. If the patient complains of it, you would have to take beta blockers off. Obviously, you will do everything in your might to make sure patient does not get this serious issue, which is going to jeopardize his mental health. Question 5, Dr. Gaur, are you asking, what are your comments on measuring and monitoring pulse pressure in all patients after an acute coronary event? Dr. Piyush, what do you think? Should we be checking pulse pressure in every body after acute coronary event?
Well, pulse pressure in particular for acute coronary events, that's not of any additional significance, as pulse pressure actually should be measured in all patients
Yes.
with or without hypertension, because wide pulse pressure is frequently a sign of aortic stiffness. And mind you, it is not limited to isolated systolic hypertension of the elderly. It is also an issue with the younger people who get isolated systolic hypertension, and we think it is because of hyperdynamic circulation. It's not so. In fact, looking at the textbook of cardiology, Braunwald, it has clearly divided the isolated systolic hypertension of the young as well as elderly, and amongst the younger people also, they have mentioned that this is because of aortic stiffness. Now, whatever the cause for that may be, but aortic stiffness is a problem even in the younger people. So pulse pressure is certainly an important thing, and it is a useful prognostic marker. The problem is how to control high blood pressure when you have high pulse pressure, because reducing systolic blood pressure beyond a certain limit in these patients does lead to a decrease in diastolic blood pressure also. And this may not be of such a great consequence in people who are free of vascular disease, but for those people who have got vascular disease, particularly coronary artery disease, it may be a great issue if their systolic blood pressure goes down to below 60 or even 70, and that's variable.
Dr. Naveen Agarwal, any comment on this issue of monitoring pulse pressure after an acute coronary event?
Or even if you monitor it, there's nothing much that you can actually do about it, as Dr. Piyush has rightly said. I mean, at the most, you can target the systolic blood pressure, get it down to the optimum level. And here I want to bring a point that Prove It TIMI 22 trial, which was, I think, published somewhere in 2010. They had said that, and they specifically looked at the issue of post ACS optimum blood pressure. And therein they said that the figure of 136 systolic blood pressure was probably the ideal blood pressure. I mean, somewhere around that range. And anything less than 130 was detrimental for the coronary outcomes. So, I mean, you can look at the pulse pressure, but actually, practically speaking, you will be only targeting the systolic blood pressure. Whatever happens to the diastolic blood pressure, whatever happens to the pulse pressure, you just got to take it as it is.
Yes, I would agree with you. That Prove It study which you mentioned was a post hoc analysis, but the Clarify registry in which we Indians also participated, had a similar kind of observation as was there in Prove It study, that the best blood pressure, systolic blood pressure post AC is around 130. Lower than that is not good, and higher than that, of course, beyond a point is also not good. Absolutely right. There is no doubt that when you look at epidemiologic data, the two things which strongly correlate with cardiovascular mortality are pulse pressure and central blood pressure. Unfortunately, these are the two things for which you have nothing more to offer to the client. This, as Dr. Piyush said, are a vascular phenomenon. Widening pulse pressure is a vascular phenomenon because of aortic stiffness, and you have at this moment very little which you can do to these individuals, and rightly so. Actually, we can. It has been suggested that using long-acting nitrites might reduce pulse pressure, but actually it hasn't been taken to any great extent. I would agree. Let's move on to the next question, because there are too many of these, and I would actually again bring in Dr. Pathak. What is his view on this? He is an intervention cardiologist of repute. And this is Dr. Biswaranjan Misra asking, is there any upper limit of BP beyond which DAPT should not be initiated in acute coronary syndrome?
Acute coronary syndrome, I think thrombolysis has a limit, sir, but otherwise DAPT, at least I'm not aware. I don't think there's any.
Yes, I agree with you. This may be a lacuna in our knowledge, but I have not read anywhere. I would agree with you. We move on to the next question. Dr. Shah is asking, which beta blocker do you recommend to your patient post ACS? So I will start with Dr. Naveen Agarwal. Which beta blockers would you recommend post ACS?
I think the recommended beta blocker is either bisoprolol or metoprolol. I generally prefer bisoprolol.
I would agree with you. The two are my choices also, and I'm reasonably happy with these. What about data from Capricorn study? Capricorn was post-MI-LV dysfunction, and these people did benefit from carvedilol and significant reduction in sudden cardiac death.
Unfortunately, there's no head-to-head comparison between the beta blockers.
Absolutely, absolutely.
There is no data to support one way or the other.
Yeah. So we have a question which I will throw to Dr. V.S. Prakash, and this is by Dr. Sahu, which says, any protective role of beta blockers in COVID-19 infection?
A good question, sir. Yeah, I think from the arrhythmia point of view, myocarditis, because we do see myocarditis and subsequent to that arrhythmias, definitely beta blockers would have some kind of protective role, primarily in patients who have myocarditis of arrhythmias. But otherwise, primarily, I mean, you don't just start any COVID patient beta blocker unless he's hypertensive and you need to control his blood pressure. But in case he has myocarditis or arrhythmia, definitely beta blockers have a role there.
Can I just come in here? No, we have seen a lot of patients post COVID who develop sinus tachycardia. So, rates going up to 130, 140, even 150. So this subgroup also, I mean, those that respond very well to ivabradine also, but beta blockers can also be safely given in this particular subgroup, and generally the phenomena lasts for about 2 to 3 months.
Absolutely right. Actually, we believe that post-COVID inappropriate sinus tachycardia probably is the most frequent complication of COVID infection.
Absolutely.
In our view, in fact, Dr. Ichepe Mencia, I think few days back, showed data from Italy, and he showed that that is the commonest post-COVID complication and complaint. But will beta blocker work or not? I definitely give it, but I don't know whether these actually will have benefit effect. Yes, sir. Please go ahead.
So, Dr. Mohan, I would like to ask you regarding this inappropriate sinus tachycardia.
Yeah.
Many such patients, they have a normal echo and other workup, and we ultimately blame it on post-COVID anxiety. But is it really post-COVID anxiety, or it is a case of subclinical myocarditis in some form? So, what is your gut feeling?
I think a good number of them have myocarditis. Unfortunately, unless you do a T2 mapping, cardiac MRI routinely, and it has to be very good cardiac MRI routinely, you would be missing good number of myocarditis. Our difficulty has been that patients have already spent a lot of money. They come out of it and sending them for CMR. We have got some CMR done. I'm not too sure that we are seeing that much of myocarditis as has been reported. Actually, some studies have reported myocarditis in as many as 76% people, those who have died. But those who have survived, I don't know what would be the number. My own guess is it would be less than about 10-20%. But I think I'll ask Dr. Prakash. Any opinion, sir?
We have data from the US.
Yeah.
We have data from the US saying that quite a few of their centers have been doing CMR, and they have found a considerable scar in patients post-COVID, which were subclinical. Some of them were subclinical, in fact.
Yeah.
And a risk for sudden cardiac death and all those. So I think probably the incidence of myocarditis is much higher than what probably we are seeing in India, because we are not really investigating thoroughly. We're not doing CMRs in all our patients.
The interesting data actually just got published from Oxford, and it says that post-discharge 90-day mortality is 5%, which seems
quite high.
Seems pretty high actually.
Yeah.
And the views which you have all expressed actually point to some kind of problem occurring. We would move on to the next question. As I said, we have many of Dr. Vijay is asking, in case of dyslipidemia, going low may not lead to immediate harm. However, in case of hypertension follow immediate complications which may affect compliance and patient confidence. What is your comment? I think I will take it and I will say, yes, I agree. You need to lower it slowly, and this tendency to start triple drug therapy right in the beginning in everybody may not be a good idea, even if you record a stage 3 hypertension, because some of them are hyper responders and they get to 90 pressure, get a fall, and they then would lose confidence. I agree with you. However, we are getting to the point that lower the better may be true for a good number of people. We still have to identify people where lower the better may not be true. And patients with obstructive coronary artery disease definitely seem to be those where lower the better may not be true. Comment, sir? Comment.
Especially going down too much on the diabetic pressure may not be good for obstructive coronary artery disease.
Yes.
I fully agree with that. That lower the better is not good for CAD patients. And I would also like to say that before we accept the results of SPRINT trial, we should be measuring the blood pressure the SPRINT way before we can actually use this in our day-to-day practice.
Absolutely. This is the exact next question actually Dr. Sethi is asking. He says, I think instead of focusing on BP target first, we should focus more on technique of measurement first. Any comment? Yeah. And I think absolutely right. One thing is certain, that following SPRINT we have moved to oscillometric method more often. one thing. And number two, we are now using equipments which actually give the average of 3 readings. At least I am using it. So I think I'm having somewhat better technique, and those 10 points with AHA has said about emptying the bladder, not taking coffee, not crossing the legs, not talking, arm this, and size properly, and nobody talking, not the doctor, not the nurse, and of course some rest. I think those things do make a difference, and we are following that. We are getting more conscious of the fact, but we still believe that the so-called white coat hypertension may be to some extent a problem of a wrong technique of measuring blood pressure. I would agree. Dr. Naveen, any point, any special thing to say about that?
I have one, issue with this particular thing. That, I mean, a person is living with a blood pressure throughout the day. He's not always sitting in a quiet room. He's not sitting without nobody talking to him. So this is not the pressure that he's going to live with. So what you are measuring by the sprint method is a very artificial pressure. It is not the pressure that the patient is living with. So, I mean, I think it's taking things a little too far. We should better focus on the pressure which an individual has to live with throughout the day. And that is not, he can't be in isolation all the time. So even if you measure it in the routine fashion, I think that's good enough.
I do agree. Actually, to be honest with you, blood pressure is something which we measure in the most sloppy manner. We don't know what we should be treating: office blood pressure, home blood pressure, ABPM got 24 hours blood pressure, the BP variability, BP volatility, or we should be having average of 2 ABPM, or maybe home blood pressure monitoring on several days. We still have actually limitations, although office blood pressure has served reasonably well for us. And this data from Raymond Hermida has also served pretty well for ABPM. But I think this is one great area where more work needs to be done. Knowing that mask hypertension is present in India in 19%. The India ABPM study says 19%. And those are the people where you are not doing anything. Probably focusing on measuring exactly would be more important. Also, as you rightly said, that measuring out of office and in various working place, correlating it with quality of sleep, quality of duration of sleep, all those things much maybe, and of course the kind of work, night shifts or day shifts, all those things may be far more important. And of course, as Dr. Piyush rightly mentioned in the beginning, some of us actually will constantly have different kind of blood pressure working in cath lab than at home, and we have seen this thing happening regularly. He's not the only person who actually developed hypertension at a young age working in cath lab because of the demands of the cath lab. A large number of people I see. To be honest, actually, I am yet to see an intervention cardiology who says it's normotency. I just want to say that thing.
See, come to think of it, I'm relying more and more on home blood pressure monitoring. Yeah. And for certain people where blood pressure is difficult to control, those who have long-standing diabetes, CKD, and particularly elderly people where blood pressure control is a priority, I'm doing an ABPM for all these patients at least once while on treatment. So that adds to the diagnosis, and I come to know of many patients who have masked hypertension, which was not diagnosed by me previously.
Yes, that's true. That's true. But a lot of people are saying that the best way of measuring masked hypertension, because that will include nocturnal hypertension, also ABPM rather than home blood pressure.
I'm talking about ABPM only for measuring the nocturnal blood pressure.
Absolutely, absolutely. Yeah. So last two questions. We need to wrap up in next 2-3 minutes. We have already taken 1 hour and 40 minutes. Dr. Singh is asking ARBs and SGL2 inhibitors both result in initial rise in serum creatinine, how to monitor such patients? I think that is simple. We have to monitor serum creatinine initially for first few weeks, maybe every week. If you are giving the combination, and in case there is progressive rise, you have to decide which is more important to decrease or stop, and then of course add. I use this combination quite often. Fortunately, the issue is not as big as is made out theoretically. So we would go to the last question, and again I'll take opinion of our experts. And this is by Dr. Muhammad, and he says, patient with hypertensive urgency, blood pressure above 190 by 100, can we give triple combination oral drugs with normal serum creatinine on an OPD basis? I'll ask you, we'll start with Dr. Naveen first.
Sir, it all depends if the patient is symptomatic. I mean, in case he's symptomatic, I would not take a chance. First of all, because the fall in the blood pressure may take a while, and the patient may develop a complication. Supposing his blood pressure is systolic is 200, he may have a stroke in the 2 to 3 hours that it might take for the oral drugs to act. That is number one. So, in case the patient is symptomatic, and in case the rise in BP is of recent origin, then I would rather admit him and treat him under supervision. If the patient is chronically hypertensive and he says that my BP has always been 180, 190, then of course I can start with a triple drug therapy and expect and tell the patient to be careful and to not venture out too much, just in case the BP shows a precipitous fall. But if it is an acute rise, patient is symptomatic, I would rather admit him and treat him under my supervision.
Dr. Pathak, let's get his opinion of Pathak, sir.
Yes, I'll go with that, sir. I think if the patient is symptomatic, then it is better to treat him under supervision and to bring down the BP to at least the levels which is safe.
Yeah. Piyush, any comment on this thing? Hypertensive
I
urgency.
fully agree. I just wonder why we are not doing a fundus examination in such patients nowadays. This is something, an area which is quite neglected. Patient with hypertensive emergency with BP of 220 by 120, and we are not even looking at the fundus nowadays.
I don't know, Piyush, but when I was doing MD medicine, you could not enter the medicine ward unless you had an ophthalmoscope in the pocket of your overall.
So that practice has been given up.
Yeah, my professor would not let me come in. I had to have that hammer, I had to have that tuning fork, this ophthalmoscope, stethoscope, and BP, and only then I could enter the ward.
It's simply because it is inconvenient. That's it.
Yeah, it is inconvenience. People have given a lot of things we have given up. I think a lot of us, even hypertension, diabetes, we are not getting even albuminuria checked. We talk a lot, give a lot of big lectures. We don't even get USCR, spot USCR, which is such an easy test.
Yeah.
We just keep talking about it. I think we had a pretty good discussion. The hypertension is a business which can go on and on because no two patients are alike. And if you combine hypertension with comorbidities it can have, then we can have, I think, a million questions any given point in time. But we need to end it. And I take this opportunity to express my gratitude to INTAS for providing us this forum, to Dr. Piyush Jain, to Professor V.S. Prakash, Major General Naveen Agarwal, and Dr. Pathak for being there with me this evening to talk about an important issue of hypertension. And I hope that in future also we would collaborate on such platforms. Thank you very much. And I give now the stage back to Dr. Mithilesh and Amit Arora.
Thank you, sir.
Please unmute yourself. Unmute. Amit, unmute yourself.
We can't hear them.
Amit, unmute yourself. Unmute. Mithilesh, give him a ring.
Sure, sir.
भाई फोटो अच्छी लग रही है यार, कोई बोलो अब। चलो अमित बोलो।
I think they're not audible, sir.
I think there is. You need to use headphones, sir. Audio is not coming. You are unmuted, but audio is not coming.
Dr. Mithilesh, you wind it up, yaar.
Amit sir, you can speak now.
I think neither of them is audible, sir. I think we can bid each other goodbye and to all our listeners.
Okay.
Yeah, I think that's a good thing.
Yeah, because
Thank you.
Thank you very much,
Okay.
and good night, sir.
Good night.
Okay.
Good night.
Bye bye.
Thank you very much, sir.
Thank you.
sir.
Thank you very much.
Naveen sir,
Thank
Dr.
you.
Prakash sir, providing us valuable insights.
Thank you.
Thank you. Thank you.
Thank you, Dr. Mohan sir. Thank you very much, sir.
Thank
Thank
you,
you, Dr.
thank
Piyush
you.
sir. Thank you very much,
And
sir.
I would also like to thank all the delegates who have joined today and participated in this digital CME. So thank you one and all for your active participation. And I would like to also thank all our panelists. Thank you once again. So good night. Have a good day. Happy weekends. Thank you, sir.